Hello, and welcome to our program, Optimizing Patient Outcomes in Bipolar Disorder, Long-Term Management of Major Depressive Episodes. I'm Dr. Leslie Citrome. I'm a clinical professor of psychiatry and behavioral sciences at New York Medical College in Valhalla, New York. I'm joined tonight by my colleague, Dr. Trisha Suppes, professor, Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine, and also at the VA Palo Alto Healthcare System in Palo Alto, California. So I want to advance the slides there so you can see our names and affiliations. And my faculty disclosures are as listed here on the screen, and those of Dr. Suppes on this screen over here. Our learning objectives for this evening is to formulate, propose, integrate, and apply. And what do I mean by that? We're going to formulate a differential diagnosis of major depressive episodes, MDEs, associated with bipolar disorder. We'll call that bipolar depression, principally by differentiating bipolar depression from major depressive disorder, MDD, or unipolar depression. We're going to propose appropriate and effective treatment for bipolar depression, and will integrate strategies for treatment of patients with bipolar depression and physical and psychiatric comorbidities. We'll apply management and patient education recommendations in current clinical practice guidelines to routine care of patients with bipolar disorder. Let's do the pre-test polling.
Thanks, Les. Trisha Suppes here. So we're going to go through a few pre-test questions, and then we'll move right into the recording of our talks, followed by a live Q&A. First question: how confident are you in the management of patients with bipolar disorder in your practice? Very confident, confident, neutral, little confidence, and no confidence. Okay, we'll go on to the next. Nope, give it another minute. Do you control the slides, Les? I think you may have to advance it.
So, actually, I don't see where I advance the slides for this.
Are the people in the background did.
Okay, well, so I've managed to turn off the pretest questions. So we're going to need some technical assistance here to bring them back on. We'll give the organizers just a minute, and maybe they can advance to the next question.
Let's do this one first. Which of the following is required to make a diagnosis of bipolar depression? Family history of psychiatric disorders, history of hypomania, somatic complaints, symptom onset after age 25, and unsure. Let's give it just a couple seconds. Okay, maybe move on to the next, please. The DSM-5 diagnostic criteria for bipolar depression are identical to which of the following conditions? Again, DSM-5 bipolar depression: anxiety disorder, major depressive episode, schizophrenia, unipolar depression, and unsure. I also will say you're going to see these questions again after the talk. Okay, let's move on to the next. Which approach to treating bipolar 1 depression is endorsed by all of the major guidelines? Avoid antidepressant use, antidepressant monotherapy, avoid SSRI use, SSRI monotherapy, and unsure. Give it a second. Then I think there might be one more, maybe two. Okay, still filling in. Let's go on to the next now, please. What is the risk of manic or hypomanic switch when treating bipolar disorder with lurasidone? Very little, minor, moderate, significant, and unsure. Okay, let's go. Is the next one maybe the last one? Yes. A 23-year-old patient with bipolar disorder is experiencing acute bipolar depression episode. The patient has a history of alcohol abuse and experienced manic episodes when treated with antidepressants prior to the bipolar disorder diagnosis. Should you be concerned about the patient's risk of attempting suicide? Yes, no, more information, and unsure. I think we've got answers. Let's move on then. We're moving to the video? Yes. So lesson, I'll be back as soon as the video is finished, and we'll be watching along with you as well. What is bipolar depression? I think, as most people know, bipolar depression was defined by at least one major depressive episode. And frequently, bipolar 1 disorder, for example, has a history of both mania, hypomania, and major depression. In fact, to make a diagnosis of bipolar 1, you don't need any history of depression. And yet, that is often the most common mood state, as we'll see in a few minutes. Bipolar 2, you need to experience a hypomanic episode and depression. But again, bipolar depression is by far the most severe, persistent, and difficult to treat element of bipolar depression. Patients often don't actually recognize when they have hypomania. There could be a kind of physiological lack of insight, but also in the more mild examples of hypomania, they may not know to define it. In fact, for them, it may be a relief from the depression. So there's an educational process that can be very important to engage with in the process of helping them develop an understanding of their illness. Depression, of course, people are miserable, and indeed that is often what gets them in to see the doctor. Now, if we look at the spread of the most prevalent polarity in terms of what they present as, that's on the left side of your screen. You see depression is the primary presentation. And I think on the right side, 67, 68% is probably even a low estimate. I think particularly as people age, increasingly depression is what their experience of bipolar depression is. If you look at some older data from Kreplin, for example, the depression is a small portion of the overall life, and then the older they get, the more depression becomes the majority. So I think it's something to keep in mind. Now, this is referring to the SF-36. That's a scale of sort of physical and mental well-being. It's not a psychiatric scale. It was developed to look at large population effects. So what you see here in applying this, it was a large sample of about 900 bipolar folks, and then compared to the general population. And you can see here that people experiencing bipolar depression rate their general health lower, but particularly their mental health is lower. And this just speaks to the degree of suffering, the degree of impact that these symptoms have on people, and the importance of treating those symptoms. You see here, it's less than 50% by comparison, and also here about 30. This is overall life functioning, and the higher you get, the more impairment there is. And you can see here, not depressed is the far left, the middle. In subsyndromal depression, you're almost as impaired as in full syndromal depression. And this is using the inventory depressive symptoms scale, a very good scale put together by Rush. This is the clinical version, but you can also use the self-rated version. So I think this nicely shows that depression, we sort of know this, right? But this is a very nice demonstration of how much it really affects people. Suicide, as we know, is a huge risk factor because of the severity of the illness, often difficulty treating, and that suicide is a very serious and real risk for folks with bipolar disorder. And that includes bipolar 1 or 2. In fact, recent studies out of Sweden, the Karanti study came out about a year ago, sampling 8,700 patients, all with bipolar 1 or 2. They found that bipolar 2s, while functioning a little better, were at a higher risk for suicide. So suicide is a very high risk, whether you're bipolar 1 or 2. And indeed, they mostly occur during depressive episodes, as we see on the right figure here, the right triangle, 73% is suicide attempts. I think importantly, the majority of people, as you see, the 20 to 60%, attempt suicide at least once. That's what we know about. I think what's so striking is 20% die from suicide. That's a very high number. It's much higher than the general population. And it's one of the reasons that we're giving this talk, which is to recognize depression and then to more aggressively treat it is very important. There's been a lot of talks about this recently. My friend Roger McIntyre has done a very nice job of getting this message out. Bipolar patients in general have higher mortality rates. So, this is a little bit small, but you can see here all-cause increase in mortality is 2 times. That's circulatory or infectious disease. But you also can see that cardiovascular, 10-year shorter lifespan. Accidental death is much higher. Homicide and violence also higher. Diabetes, which can go along with the cardiovascular, quite a bit higher. And suicide is 10 to 30 times. The overall impact of all these factors is that the lifespan is shorter. Usually people talk about it being a decade shorter. My friend Michael Ostacher says quite rightly that cigarette smoking contributes to this number, and yet we don't always recognize that's a big contributor, for example, to cardiovascular disease. And I think the good news on the horizon is we're getting this message out, and some of the newer medications, which we'll talk about in a few minutes, do not have the same risk pattern for metabolic impact. Okay, so misdiagnosis, underdiagnosis, and overdiagnosis are very common in patients with bipolar. So this was in a screening tool, but who did not receive a diagnosis, about 20%. Probably this number is a little higher. The misdiagnosis is about right. Most patients first come to the doctor in depression, as we discussed, and I'd say over 50% of them may be diagnosed with unipolar depression. Other diagnoses include, quarter of them probably, anxiety disorders, schizophrenia, personality, substance use, and other. I think what's important to remember is folks with bipolar disorder will not recognize unless there's some reason, such as a family history they know about or a relative they know about. They may not recognize the cyclical nature or hypomania or mania. So I don't think it's too surprising. There's also evidence there's overdiagnosis, so it's important to keep that in mind as well. This is less so than it was, say, 5 to 7 years ago, but there was a tendency that if it walked and talked and looked cyclic, they called it bipolar disorder. So I think one also has to be mindful of that issue. And indeed, very significant consequences of the misdiagnosis. It matters if this misdiagnosis happens. For example, people can develop more substance abuse because they're trying to manage their own illness, which can have impact on the brain and indeed can then have impact on the overall course of illness. Also, initial treatments, inadequate or inappropriate. I think it's fair to say we would expect there would be continued symptoms if they're not on the right treatment. And also there's bad communication about what is this illness? How do we need to manage and treat it? So those are all important impacts from misdiagnosis. Differentiating between major depression, bipolar 1 and 2, and a person with longitudinal. Basically, the episodes are indistinguishable. Criteria are the same. So really, the critical element is to look in the longitudinal history. And that requires, if you can, not just interviewing the patient, but also someone who knows them or is close to them as part of the intake. This is assuming you're outpatient. Now, if you're inpatient, it's a whole nother deal because they might be in for mania, but this is assuming, which is where the most folks come in, they're presenting for depression. But if they're just depressed, and they may not define the hypomania that is a prelude, for example, to getting fully manic or bipolar 2 hypomania. So one of the questions I always ask them is they're still depressed, but do they now have energized depression or that kind of description to sort of get at periods where they aren't just euthymic or depressed, but they're depressed plus mixed features. And that could help sometimes piece apart if there's hypomanic episodes. So as we know, bipolar 1 lists history of at least one manic episode. Bipolar 2, they have to have depression and one hypomanic episode, but no mania. Bipolar 1, the ratio of major depressions is about 3-1. In bipolar 2, they say 39-1, but there's actually data that supports that's actually probably not right. That's from the Judd study in IMH Collaborative, where they talk to them only every 6 months, and people don't remember their hypomania. In the study led by Ralph Kupka, looking at life charting, it was a much lower ratio. It wasn't 3-1, but it wasn't 39-1 either. So bipolar 2 folks are a little less prone to hypomania, but it's more like 7-1 or something. All right. We're not talking too much about the mixed features today, but we could certainly do that in Q&A. All right, so differentiating. These are not hard and fast. These are clues that might lead you to look deeper. Again, depression is probably what's going to bring them into your office. That's very important. But then you have to kind of look at the surround, because it's a groundwork the patients don't yet understand. So sometimes you see these differences, not always. Age of onset can be earlier with bipolar. Importantly, the family history of psychiatric disorders, not so much the frequency, but what is that family history, and really unraveling it, particularly if someone has relatives from the 50s, 60s, and 70s, which are beginning to seem very long ago. They may not have been diagnosed bipolar, but they might have had electric shock therapy. So you have to kind of look for that. Hypomania, again, they won't recognize it. You have to go through an educational process. Atypical depressive features, sometimes people feel it's more associated with bipolar, sometimes they don't. But the cyclicity and the frequent recurrence of mood episodes, I do think, is probably a little bit higher than major depression. I'm going to turn this over now to Les Citrome, and he's going to talk for a bit about screening and a couple other issues.
Well, thanks, Trish, for a wonderful overview of bipolar depression and some important aspects about making sure we got the right diagnosis. How do we do that? Well, we need to ask the right questions, right? We need to be systematic in our approach. So one way of doing that is using a variety of aids. And the mood disorder questionnaire is probably the one that we're most familiar with. It allows us to screen for bipolar disorder by asking patients a variety of questions about prior behaviors, experiences that would be reminiscent of mania or hypomania. And it's sometimes difficult for us to have this conversation with patients, and sometimes it's easier for them to fill out a form. And sometimes I'm surprised on how honestly they would fill out a form and otherwise deny things to me when asked directly. For some reason, that can happen. So the mood disorder questionnaire actually allows them to describe whether or not they felt so good or hyper, or that they were irritable or more self-confident than usual, or actually an important one, needed much less sleep than usual. So it's not a problem of not being able to sleep because of insomnia. It is like not needing to sleep because you're full of energy. That's a very big difference. And if a patient tells you, yeah, I didn't need to sleep as much, I was just, so full of energy, well, that's a lot different than if they tell you, I just can't fall asleep and, I want to go to sleep and I'm tired. If they were able to identify people telling them that they're talking too fast or too much and getting that kind of feedback, that would be helpful for you to consider. And the mood disorder questionnaire addresses that as well as other things. And basically, you count up the number of yes responses on the mood disorder questionnaire, and you also inquire about the effects of these symptoms or observations have on the patient, and you use that as a clue as to what to do next. It's not diagnostic, but it helps you address things in a systematic way. Now, some of you may be saying, boy, that's a lot of questions, and that's kind of burdensome. And some patients may find this is a lot of questions too, and they have enough trouble with the PHQ-9, never mind doing the MDQ. So there's another way that is being developed called a rapid mood screener, 6 items. And these 6 items have been identified as being quite distinctive as helping distinguish between unipolar and bipolar depression. The sensitivity and specificity was actually quite good. And compared with the mood disorder questionnaire, I think it's going to be a reasonable competitor to the MDQ. But we don't know much about the RMS. It is new, but it may be better adopted because it's easy to complete. It's brief. So this will be helpful because one of the key elements in treating a patient effectively is knowing what diagnosis you're addressing. Treatment for major depressive disorder differs from bipolar depression. In fact, treatment for MDD may worsen bipolar depression. Case in point, I'm sure we've all had experiences with this before, not really knowing what kind of depression a person has. We make the assumption they have MDD, and perhaps, that was based on the best information available, and yet you give them an SSRI or SNRI and they don't do better, or they seem more irritable. And sometimes, actually, not a regular occurrence, they may flip into mania. And when that happens, you'll never forget it. So obviously we made a mistake there, not because we were neglectful, because we just didn't have that information. The MDQ and RMS will help us make sure that we systematically ask the right questions. Now, sometimes it comes up, the mixed features. I do want to spend a couple of minutes talking about it. It's commonly encountered, and what do I mean by mixed features anyway? In the old days with DSM-4, we had the mixed episode, very explicitly outlined as having full-on mania and full-on depression for at least a week. I don't know about you, but I never encountered that in my private practice. Maybe in a hospital, but patients wouldn't necessarily make an appointment to see me if they were full-on depressed, full-on manic, and waltzing into my office. No, it would be they're depressed and I see them in my office. When there's ever mania, there's very little insight into it. In any event, having both full-on mania, full-on depression, that's a very serious condition. But what about a patient who has a major depressive episode and they have a touch of mania or hypomania, just a few symptoms here or there? Well, that makes them a bit different, doesn't it? And it may make our choices of medication different too. And more work is being done in this, but here's an example of how common we'll encounter these mixed features. A hint of hypomania amongst our patients with major depressive disorder. It turns out to be actually about 1 out of 4. And for those who have actually a major depressive episode associated with bipolar 1 or bipolar 2, of course, we would expect that percentage to be higher with the mixed features, with a hint of mania or hypomania combined with their depressive symptoms, about a third. This is not unusual. So actually, we can use this to our advantage. It helps us identify patients who actually may benefit from a strategy that would be more geared towards bipolar depression rather than unipolar depression. Now, there's this 4 A's that we've learned about for schizophrenia years ago. We can take the 4 A's and rework this to help us increase our suspicion of mixed features. The 4 A's here being proposed by Roger McIntyre are anxiety, agitation, anger/irritability, and attentional disturbance distractibility. Should we see this in combination with dysphoria, with the symptoms that are consistent with a major depressive episode, this makes us more suspicious of mixed features. And after all, mixed features will point us in another direction in terms of treatment, one that would be consistent with that for bipolar depression. So we'll screen patients with depression for bipolar disorder. We'll do this routinely in order for us to select the correct treatment, and we'll go over some potential choices shortly. The MDQ, as I described before, is a bunch of questions, actually 13, assessing symptoms and functional impairment, and has pretty good sensitivity and specificity, but the Rapid Mood Screener has just as good sensitivity and specificity and is shorter. Now, we need to screen, and if only we screened, we may have a better, more accurate diagnoses and more targeted treatment that would actually work. And let's not forget to supplement our clinical interview and history taking with the patient with history taking with family involvement, significant others, regarding any potential history of mania or hypomania. As was mentioned, insight into mania or hypomania may be fleeting or absent, but insight into depression is painfully real. So patients will talk a lot more about depression and dysphoria than they even would consider even introducing talking about their past feelings of feeling better. Let's frame this in a case scenario of Sue. It helps us gel all this information together. She's a 35-year-old woman. She presents with depression and reports some atypical depressive symptoms. Sleeping a lot, has no energy, but sleeping a lot differs from the usual insomnia complaint of a major depressive episode associated with MDD. But let's not hang our hat on that. Let's find out more about Sue. Well, we find out that she has a history of MDD since adolescence. Well, okay, an adolescent can certainly have a major depressive disorder, but early onset of a mood disorder is reminiscent of bipolarity. Make us think more about that. In addition, she was previously treated with an SSRI monotherapy based on the MDD diagnosis, but didn't improve. When someone doesn't improve for a diagnosis that you make and that you treat according to diagnosis, they don't improve. One of the things I think about, in addition to non-adherence, is maybe I made the wrong diagnosis. She has a history of hypomania, as we discover, as we ask more questions, and her chart shows several hospitalizations, if only we looked at the chart, for manic episodes while on an SSRI. She doesn't remember the details. Now DSM-5 allows us, by the way, to take this history of SSRI-induced mania as part of the diagnostic criteria for bipolar disorder. She also has potential substance use, alcohol, although people with MDD can certainly misuse substances and alcohol. It may be more commonly encountered in those with bipolar disorder. And then the clincher here, in my mind, is the family history. Through questioning, she reveals that both her aunt and her grandmother had bipolar episodes. Well, that's pretty strong evidence now that Sue doesn't have MDD. Her presentation and history does not really support the diagnosis of MDD. We'll also obviously screen her for substance use currently, because sometimes patients will present with mood instability because they're misusing substances. But the other side of the coin is that they may be self-treating their mood disorder with substances. It can work both ways. With Sue, she's not plain vanilla MDD. There's something else going on, and this sounds like bipolar depression. So we'll need to treat bipolar depression effectively. In order to do that, let's run through the array of treatments that we have available for bipolar disorder, and we can divide it into the different phases of treatment. Acute bipolar depression involves some treatments that are kind of unique and different, perhaps. Acute mania, another list, and maintenance, a subset of the prior lists. And basically, the FDA has approved a variety of choices. Much fewer choices have been approved for acute bipolar depression by the FDA, by the way, only 4. Cariprazine, lurasidone, quetiapine, and olanzapine fluoxetine combination are the only treatments approved by the FDA for acute bipolar depression. Now, this may be joined later in the year by lumateperone, which is in front of the FDA for consideration, but right now it's only 4. I look forward to more choices because 4 is not enough. And if we look at the number of choices we have available for acute mania, they're much more than 4, and for maintenance, much more than 4 as well. I like to have choices because each of these different choices have different profiles in terms of tolerability and suitability for the individual patient at hand. Let's get back to acute bipolar depression for a moment and take a look at the treatments approved, and below that are the treatments not approved by the FDA. Lumateperone will move towards the approved list shortly, but lithium, lamotrigine, antidepressants, not approved. And yet we use those quite often. And perhaps we do it out of ignorance of what's approved, and perhaps we use them because they worked in the past for that individual patient. And if they worked in the past, we'll continue using them. But I wouldn't necessarily start someone on lamotrigine for acute bipolar depression. And I would gravitate towards something that's approved for this purpose because the efficacy was demonstrated for it. Antidepressants, in terms of monotherapy, I do avoid in bipolar depression. It could destabilize the person. At best, of course, it helps them, but in terms of harms, at best, it does nothing. At worst, it causes more irritability, and you really don't want to induce mania in anybody. Let's talk about the treatments with FDA approval for acute bipolar depression. There's lurasidone, quetiapine immediate and extended release, olanzapine fluoxetine combination, and cariprazine. The relevant indications are very similar one from the other. The mechanism of action does differ, at least the nominal mechanism of action. We're not quite sure how any of these work, but we have some idea that maybe with lurasidone, what we're encountering is this 5-HT7 antagonism that may be important, and partial agonism at 5-HT1A and so on, and that may play a role. For quetiapine, there's an active metabolite, norquetiapine, and it inhibits noradrenaline reuptake. It's also a partial 5-HT1A receptor agonist. Olanzapine fluoxetine combination, we believe there's the synergism here, at least that was how it was presented when first introduced, resulting in relief of symptoms of depression. And with cariprazine, we're intrigued by this D3 receptors, this dopamine D3 receptor, where cariprazine serves as a partial agonist. So each of these four choices has a putative mechanism of action which differs perhaps from other choices. But more importantly, they're supported by randomized placebo-controlled clinical trials that supports their use. Now, what about the antidepressant monotherapy that we don't use, or we shouldn't use, and why are they not recommended? And why do the guidelines are so vehement about avoiding antidepressant monotherapy? Well, number one, inconsistent evidence of efficacy when actually tested. Number two, it may induce hypomania, mixed states, or rapid cycling. We don't want that. It might actually worsen the depression, can increase the risk of suicidal behavior, may cause agitation, dysphoria, restlessness, mania, or other features as evidenced in one publication as described using those words. Now, the switch for mania is greater than for our older antidepressants and maybe for the SNRIs, but it's something that is relatively uncommon regardless. But if it happens, we know that a manic episode can be associated with behaviors that have consequences that may be irreparable. No antidepressant is FDA approved as monotherapy for bipolar depression. That we can say with certainty. Now, how do we actually assess whether one medicine works and how well does it work? Well, we can't just depend on p-values. P-values will only tell us how strong the likelihood that anything we see is the truth or not. And if a drug beats placebo and the p-value is less than 0.05, we're pretty comfortable in saying we're dealing with a real effect. It's not due to chance. The smaller the p-value, the more convinced we are that it's not due to chance, but it doesn't tell us anything about the size of the treatment effect. It doesn't say anything about that. If a drug beats placebo and it does so at a threshold of a p of less than 0.001, doesn't mean it's any more powerful than a drug that beats placebo at a threshold of 0.05. Doesn't really explain the size of the treatment effect, doesn't explain effect size. So we can't use the p-value as an effect size. We have to use something else. So let's turn to the metrics of evidence-based medicine. And some of you have heard these terms and others have not. Number needed to treat and number needed to harm are effect size measures in people units, patient units. Nntnh answers the question, how many patients would you need to treat with intervention A instead of intervention B or placebo before you would expect to encounter one additional positive outcome of interest, like one additional responder or remitter. Number needed to harm is Nnth's evil twin, so to speak, and it measures things we'd rather avoid. It answers the question, how many patients would you need to treat with intervention A instead of intervention B or placebo before you would expect to encounter one additional outcome of interest that you would like to avoid, such as one additional patient complaining of being sedated or having akathisia or gaining weight. We want to avoid those outcomes. So we want medicines that work and medicines that are tolerable. So basically, this is the definition of effectiveness. Will it work in the real world? Well, in order for something to work in the real world to be effective, it has to be efficacious, reduce the symptoms, has to be tolerable and safe. So we want to avoid side effects as much as we can. And the patient has to be, of course, willing to take the medicine. That's when we'll have a medicine that works in the real world. We can actually use Nntnh and Nntnh to quantify benefits and risks and kind of assess how potentially effective a medicine would be over time. we would want a small Nntnh versus placebo, for example, to show that we'll anticipate benefits often. So if it only takes a handful of patients to be randomized to drug versus placebo in a randomized controlled trial before anticipating one additional responder or remitter, it only takes a handful, well, that's good. And we're going to encounter benefits pretty often. What about NNHs? We want those numbers to be sky high versus placebo, because we don't want to have to encounter extra patients who have a complaint of, let's say, feeling tired, having akathisia, or gaining weight. What's an important Nntnh? Well, the mythical Nntnh of 2 would be hugely important. That's as low as you can get. It takes only 2 patients to be treated with one agent versus the other before expecting one additional remitter or responder. We don't really see that very often in medicine, and particularly in randomized controlled trials involving placebo. People on placebo do get better, right? Of course, why wouldn't they? They're in a structured research setting. They're getting tender, loving care, regular meals. If they're in a hospital, getting paid for their participation, they will show improvement. Drug usually beats placebo, but the Nntnh won't be a 2. It may be a 5, 6, or 7. That's fine. Any Nntnh that's less than 10 are important and will result in differences we would notice in day-to-day clinical practice. So rule of thumb, Nntnh versus placebo of 10 or less, I prefer the lower the better, then this medicine will have a useful role to play in day-to-day treatment. What if the Nntnh is greater than, let's say, 100? Well, it means it took 100 patients to see a difference when selecting A versus B for the outcome we're interested in. Let's say you have a randomized controlled trial of drug versus placebo and the Nntnh was 100. Means you have to randomize 100 people to the medicine versus placebo before expecting one additional responder. Well, I would say that's a useless medicine if it comes to response. But there's always exceptions in medicine, right? What's the reason we use statins? The Nntnh is over 100, but it prevents heart attacks, stroke, and death. And what's the big deal of taking a statin? Not much in terms of tolerability for most people. So it depends on what you're measuring too. It depends the context. But for our context in the world of psychiatry, in bipolar depression, 10 or less would be okay. Now, some Ntths may be irrelevant. Let's say you have an NNH of 3. For every 3 patients you randomize the drug to instead of placebo, they have one additional adverse event. That doesn't sound good. That happens. You'll see it all the time. But what if it's mild dry mouth? Who cares? Mild dry mouth will not drive treatment decision making or patient acceptability under most situations. So we'll have to use our brains here when interpreting Nntnh and NNH and think about the outcomes too. So evidence-based medicine is not a cookbook, and the metrics are not used in a blind fashion without thinking, but they can be very helpful in helping quantify harms and benefits. So let's talk about the outcomes of interest in studies of acute bipolar depression. We can calculate number needed to treat for response and remission. We can define response on the Montgomery-Åsberg Depression Rating Scale as a 50% or greater reduction from baseline to endpoint. And we'd all agree that a 50% reduction is good. We'd want to see that. Even better, we want remission. That is a total score less than a certain threshold. And we can quibble on what threshold we want to use, 12 or 10 or 8, even lower. I like, of course, remitters to have no symptoms, but let's be realistic here. The number needed to harm can be calculated for adverse events, such as an increase in weight of at least 7% in the short term, an adverse event rate for sedation or somnolence or akathisia, or basically any adverse event that would be of interest to the patient or the clinician, or both. Let's take a look at Madras responders for bipolar depression. We can look at the number needed to treat for cariprazine, lurasidone, quetiapine, and olanzapine fluoxetine combination. And I've taken these numbers in terms of response rates for drug versus placebo right out of the clinical trials that led to approval for each of these agents by the FDA. So there was a 46% observed response rate for cariprazine versus 36% for placebo. That results in a number needed to treat of 10. For lurasidone, it was 52% versus 30%, which results in an Nntnh of 5, and so on down the line. Olanzapine-fluoxetine combination has the most robust Nntnh of 4. For every 4 people randomized to olanzapine-fluoxetine combination, you would anticipate 1 additional responder. Well, that's pretty good. Sounds better than 10, so why don't we use OFC all the time? Well, there are 2 reasons. One is that 10, 5, 6, and 4 are close enough. And I want to mention that because the 95% confidence intervals, those are those vertical lines going above and below the Nntnh estimates, they all essentially overlap. So actually, truth be told, I think you'd be hard-pressed to see a difference in Madras response, one for the other, all other things, being equal randomly, patient by patient. Of course, if you know someone responds well to one versus the other, you'll use that. But if you don't, well, any of these 4 might be reasonable, just in terms of the Nntnh. Now for remitters, here the definition does vary a little bit between the agents, depending on how the different manufacturers report this in clinical trials. I could only calculate it with what's available to me publicly. So I calculated for cariprazine a little differently than for the others because the threshold was different. 10 or less for cariprazine, 12 or less for the others. And I come up with actually Nntnh estimates for remission in kind of the same ballpark in terms of the overlap of the 95% confidence intervals. So with all that, we see there's a small spread for Ntths for response and remission. So what's the difference? Well, it's going to be basically how they're tolerated. Here's a heat map, as I like to call it, of various harms that we consider. Weight gain of at least 7%, the presence of extrapyramidal symptoms in terms of drug-induced Parkinsonism, somnolence, akathisia, nausea, and an overall discontinuation due to adverse events. And I have here the number needed to harm versus placebo for all the agents that we talked about, including different doses of some of the agents. And that gives us an idea of how often we would expect to encounter various adverse events we would rather avoid. In red are those number needed to harm values less than 10, which denote a higher risk. So for example, OFC for weight gain, the number needed to harm was 6. For every 6 patients randomized to OFC versus placebo, you would encounter 1 additional patient who has gained at least 7% of their body weight. That's almost as often as you would encounter response or remission, by the way. For quetiapine immediate or extended release, I pulled together all the data here, the number needed to harm for somnolence was 3. For every 3 people randomized to quetiapine versus placebo, you would expect 1 additional patient complaining of somnolence. That's actually about twice as often as you would expect response or remission. So we're prepared to encounter somnolence when we prescribe quetiapine. What about lurasidone and cariprazine? Mostly a sea of green, which means the number needed to harm values greater than 20, low risk. And I wouldn't necessarily expect any of these with regularity when using these agents. With lurasidone, there seems to be a dose response in terms of tolerability, so I gravitate towards the lower dose, 20 to 60. Cariprazine, that dose response is somewhat less accentuated, but still there with guiding akathisia. So the lower doses, lurasidone 20 to 60, cariprazine 1.5 milligrams per day, gives us mostly green, maybe a yellow here and there for intermediate risk for the harms. So I can conclude that I would achieve benefits more often than harms using the 2 newer entrants into our choices for bipolar depression. Now, how will lumateperone play in here? Well, that remains to be seen. I'm waiting for it to receive approval for this indication by the FDA. And I'll take a look at the product label and I can calculate the number needed to harm based on that for bipolar depression. And I'll add another column to this heat map. Obviously, bipolar disorder is a complex disease. It's challenging to treat. We often end up using combination approaches. Trish, take us through that.
So the next few slides, I'm going to talk about not the treatment per se, but a little bit more in the complexity, comorbidity, and also more surround issues like overall health. So it is indeed a complex disorder. And I know that both Les and I feel we can't really do it full justice in this shorter presentation, but we're trying to present some of the key points to give you some good starting places. So obviously you're always going to try to minimize how many medications you use, but often there does seem to be a need to do add-on. So there have been some large studies which have shown that add-on can be helpful, but you're also getting increased side effects. And in some placebo-controlled adjunctive studies, in fact, the benefit may be minimal, but the side effects could be large. So it's important to both balance those two issues. It is very common to need adjunctive, but it's something to remember is maybe you don't need adjunctive, or maybe if you're up to 3 or even 4 medicines, maybe you don't need all those medicines over the long term. So it's possible later to consider pulling off non-essential meds that aren't focused on current target symptoms or overall mood stability. So we do add on. The numbers I usually provide are 25%. You're going to have to throw the kitchen sink at them, which even then may not be enough, using really some of our higher gun medicines like clozapine and so on. 50+% are going to do pretty well when you get them balanced on adjunctive, and about 25% will do monotherapy and be in good shape. So that's pretty much what Joe Goldberg talked about a few years ago, and that certainly fits my experience. So it's kind of a rule of thumb to keep in mind. And most folks in practice are probably treating people in the middle, the adjunctive therapy. And that's part of what makes treating this illness complicated, because you are having to balance more than one medicine. Now I want to move a little more into the physical elements, talking about the cardiovascular and metabolic comorbidities, which are very prevalent. And part of the issues that have led to the development of these newer medicines that Les went over very nicely is the difference in the side effect profile. So it's important that we have a whole range of medicines we can use, but if we can minimize the harm, minimize serious side effects such as significant weight gain, that will affect the overall well-being for our patients. We know absolutely that higher body mass index affects the whole body, affects well-being, affects the development of diabetes, huge metabolic risks. So it's important to have conversations, I feel, of the person who's caregiver, the group of whether whoever makes up the caregiving team and prescribers, to discuss these issues and talk about overall attitudes towards health. Again, I'll bring up this issue of smoking, which is often not recognized and discussed, but the hypertension, the blood work, being sure you're not pre-diabetic, and some focus on abdominal obesity. And this may lead us to be partnering with the whole caregiving team for folks with bipolar. Something to remember, bipolar disorder, like all chronic persistent mental illnesses, is going to be with someone for the lifespan. So just as our bodies change and need different things in different decades, they will also change. Just as they may need different psychiatric meds as they age, they're also going to need more medical surveillance and monitoring and engagement with a team of collaborators if possible. The team could include primary care, looking at a lot of these metabolic issues. Mental health is obviously a big part for folks. I could say much more on this, but the main thing is to be aware of it, that these are things we're going to want to talk to the patients about. Now, just as there's medical comorbidities, which may or may not be related to the medications we provide, there's also psychiatric comorbidities. And in fact, bipolar disorder 1 and 2 really has the most comorbidities, co-occurring illnesses of almost any major medical illness. So the anxiety disorders, including PTSD, can be well over 50% co-occurrence. Substance use lifetime prevalence is over 50% as well. And eating disorders, which we often don't focus on, can even be 10% or a little bit more. Now, particularly for the substance abuse, you're going to really want to screen for these things. I think Les pointed out nicely that if you're not getting a predicted response, you both review your diagnosis and also whether there could be substance use complicating the picture, so to speak. And I found that you can't just ask someone whether they drink. You always have to ask them, how big is the glass? How big is the pitcher? I've had folks tell me they have one glass of wine a night, and then it turns out it's a half bottle. So just that kind of, you have to sort of get into a bit more detailed questioning on all of these issues, including anxiety disorder, substance use, and so on. The importance of the management strategy here is that you're not just going to be managing bipolar disorder. You're also going to have to address the co-occurring symptoms. Sometimes that won't require medicine, but a lot of time it might. And that, in fact, creates even greater complexity. It may require meds for anxiety disorders or cognitive behavioral therapy, depending on what the issues are. Substance use may require a different range of counseling. Some folks I've noticed are self-medicating, but some folks, even when the bipolar disorder is stabilized, they continue to use. So you can't assume one will take care of the other. So let's talk just a few minutes about a case scenario. So Mike's a little bit older. He's 57. His presentation, when you're seeing him, is depression. So one thing about his age, he's going to be more prone, of course, to more physiological issues, cardiovascular, weight, and so on. You know, he's in a different decade of life. He is diagnosed with bipolar disorder. I'm assuming bipolar 1 disorder, though it's not stated. He was misdiagnosed, which of course is very common. And there's evidence of cardiovascular disease and diabetes. So family history is limited, but I think his presentation history is clear enough that even without that, we can address that he wants to avoid weight gain. And we need to consider, I think, the newer agents for treatment management of his depression. It also would probably be worth considering whether he's had lithium or not. Lithium is a first-line agent in all guidelines because sometimes it can create a greater mood stabilization, and then you can add on the newer agent, and that the two together can provide really excellent stabilization. So those are the kinds of things I would give some thought to in being presented by an older man with this kind of history. I'd want to look at their medication history, and in choosing agents, I would want to do things to minimize weight gain or anything that could impact his cardiovascular history. I think you'd also want to be sure to collect substance use history, including cigarettes here. Les talked about this a bit, but it's very important. There's a lot of contributors to non-adherence. When you look at some of the papers that talk about non-adherence, it's more common than not. So it's very important that we talk about adherence with the patient. We make sure if they're having side effects, these are tolerable side effects to them, that it doesn't preclude their continuing on the medicine. We don't want them to minimize their side effects because we want to understand what they are. So some of these can contribute, obviously. Illness, polypharmacy, tolerability, if things aren't working, lack of efficacy. The physician rapport is actually very important to work with the patient, and motivational interviewing can help. It's really seeking what is motivating the patient and using that as the platform to engage them with treatment. Of course, you want to look at logistics, including insurance, transportation, and so on. All right, so now I'm going to talk a little bit about, just briefly, a couple slides on best practices in patient education, and then we'll close with a summary. So these are the clinical tasks in optimizing treatment for mood disorders. And today, of course, we're talking about bipolar 1 and 2 and bipolar generally. So you have to engage the patient. If you haven't engaged them, things aren't going to go well. They may not come in when they're feeling particularly bad. And with bipolar folks, more than any, it really is a collaboration. Many of them will want to maintain some degree of a locus of control. So for example, you might have a plan with them. If you get a little worse in certain ways, this is how they manage it, and then they call you. Obviously, resolution of whatever type of episode we're dealing with is critical. People want to go back to whatever their function is, and symptom control. And then, of course, relapse mitigation should be part of the treatment plan in all cases to have an agreement on what is their prodromal symptoms. How are we going to manage it? So you've already had those conversations before things actually happen. So this is the overall chronic disease management that goes across all illnesses. So you have self-management. You want to empower them, prepare them to manage their health. And you have decision support. That would be part of the motivational interviewing, for example. It's also about the evidence as well. I think decision support is also part of what the patient is about. Also, providing them with education, not just about the illness, but about the medications, because you might be the primary conduit, besides the internet, for folks to learn about medicine. So it's important that they hear from you as well. And then the community, if you can engage folks in community programs, there's a number of them for people with bipolar disorder. And these other factors I think are also important. Again, delivery system design, how are they going to take care of them? I like some of these, we don't use these enough, clinical information systems, and then looking at the overall health system. This is the kind of slide we probably could do an entire talk on. So in summary, accurate diagnosis is absolutely critical if you're going to pick the right treatment and look towards the best outcomes. The MDQ is one tool and the Rapid Mood Questionnaire is another, but neither of them take the place of really good interviewing with the patient, because if they don't have insight about something, they may not be able to report they have it, and that's why both are needed, I think. There are currently 4 approved FDA treatments for bipolar disorder, different risk benefits. And obviously, they should be individualized. We expect another one soon, which will be good to add to that armamentarium. Bipolar disorder is indeed a lifelong illness requiring lifetime management, and treatments look to minimize symptoms and enhance function while not impacting negatively the overall physical well-being. And I think collaborative care, both of us have stressed this throughout the lecture, is really important for success in the treatment of someone with bipolar. Thanks very much. Look forward to your questions and answers.
Hope that you found this discussion informative. Now, before we'd open it up for Q&A, let's go through the post-test to gauge what we've learned. I'm going to go over each of the questions that you actually answered before we started. So let's begin. Which of the following is required to make a diagnosis of bipolar depression? Family history of psychiatric disorders, history of hypomania, somatic complaints, symptom onset after age 25, or unsure? Well, let's close this question because I think everyone answered correctly, history of hypomania. And that was an improvement from almost everybody to everybody got that one correct. Next question, which approach to treating bipolar depression is endorsed by all of the major guidelines? Avoid antidepressant use, antidepressant monotherapy, avoid SSRI use, SSRI monotherapy, or unsure. Again, these are just too easy. I thought it was too easy. The correct answer is avoid antidepressant use. That probably is the best answer, but I can see why you would say antidepressant monotherapy. So now I'm not so sure which one would be the best answer. So, of course, just to reiterate, exposure to antidepressants is controversial. Antidepressant monotherapy is probably a bad idea. Avoiding antidepressant use entirely, well, okay, that's a little debatable. Okay, let's go to the next one. The DSM-5 diagnostic criteria for bipolar depression are identical to which of the following conditions? Anxiety, MDD, schizophrenia, unipolar depression, or unsure? So, bipolar depression is defined by a major depressive episode in the context of a history of mania or hypomania. Major depressive disorder, or unipolar depression, is also a major depressive episode, but without a history of mania or hypomania. So maybe the next time around we'll rephrase these questions to make it more clear. A major depressive episode is not technically a condition, it's an episode. It can either be bipolar or unipolar? Bipolar if there's a history of mania or hypomania, unipolar if there is not. Let's go to the next question. What is the risk of manic or hypomanic switch when treating bipolar disorder with lurasidone? Yes, it is limited. I'm not sure if we really actually address this to the extent that we could have in the didactic portion of the presentation. But in general, when we use a second-generation antipsychotic, we don't necessarily expect mania or hypomania. And so they've been successful as monotherapies in the treatment of bipolar depression. At least some of them have established that indication through the conduct of trials suitable for FDA approval. All right, next question. A 23-year-old patient with bipolar disorder is experiencing an acute bipolar depression episode. The patient has a history of alcohol abuse and experienced manic episodes when treated with antidepressants prior to the bipolar disorder diagnosis. Should you be concerned about the patient's risk of attempting suicide? Yes, you sure should be concerned. So we'll do a risk assessment. We'll be very careful with people like this. And that's it for our post-test polling. So everyone, I think, did reasonably well. We screwed up with some of the wording of the questions, but that's on us. Let's now proceed to the Q&A. And in order to do that, I need to look at the chat. And I wish I knew where that was.
It was on the left. Can maybe downsize the QA slide so that we can see?
Ah, there it is.
Yeah. Can you downsize the slides maybe?
My slide was controlled by magic, and I can now see the questions. Okay.
Okay.
First question here. In addition to the MDQ, are there any other screening tools or tactics that you use to determine if a patient has bipolar depression? Trish, what do you do?
Well, so what I try to sniff out is if they're having depression, but with some degree of hypomania. That expression, energized depression, is something people seem to relate to. So if I basically say you're just as depressed, but now you have a bunch of energy, you don't know what to do with it, you might be very irritable, that kind of opening seems to, people can relate to it experientially if in fact they have bipolar depression. So I don't ask them like, do you have hypomania? I ask them more symptom-based kinds of questions. So yeah.
So the MDQ will do that for you, essentially. It helps you make sure that you've asked all the questions. And again, patient fills it out, and they may fill out a form more honestly than answering your questions. There's also the rapid mood screener, which is brand new. We're getting experience with it now, and stay tuned. Maybe that'll be an alternative that is easier to use because it's shorter.
Yeah, I like Les's idea that you really need to do both the screening tool and the diagnostic interview. I think it's important. Yes,
screening tools are not diagnostic. They just help you think through the various possibilities that you might be dealing with. Well, here's a question that I always get, and I'm sure, Trish, you've heard a million times. Do you ever use antidepressant therapy when treating patients with bipolar disorder? We're all guilty.
Oh my gosh.
Yeah.
The statistics are clearly indicative that people use a lot of them. And for bipolar 2, there are studies that support antidepressants might actually be the right treatment for monotherapy. Now, that's not true for all bipolar 2 folks by any stretch, but there are some where that's useful. So I'd have to say yes, but cautiously, judiciously, thoughtfully.
Yeah. So it wouldn't be my first choice. I really try to avoid it. I don't want to expose them to not getting better. That could certainly happen. Or getting more irritable, or cycling, or inducing mania. But what if I see a patient who tells me, and it's confirmed by family, that they've been on an antidepressant before and it's helped them and they didn't get into trouble? Well, then that changes everything, doesn't it? Evidence-based medicine is not only about the evidence, it's about your clinical experience as well as the patient's preferences and values incorporated together with the evidence. So that decision will change depending on the facts at hand. So yes, sometimes we use antidepressant therapy when treating patients with bipolar disorder, but it's not preferred. So this brings us to the question here: what factors influence your choice of an approved treatment for bipolar depression? Trish?
Well, first of all, I assess whether it's someone who has bipolar 1 or 2 disorder. I collect what in the past they may have had and what's been helpful to them. I make sure that they're on a mood stabilizer, particularly if they're bipolar 1, of course. And a mood stabilizer that might have antidepressant efficacy is good. So, lithium or even an anticonvulsant to which you add one of the newer atypicals that you reviewed would certainly be viewed as reasonable approaches to treatment. Now, lorazepam doesn't have anti-manic approval, or it's not approved to treat mania. Cariprazine is approved to treat mania. So that could influence whether you try to go for a single or combination agent. I think, patient preference and willingness to try something to sort of where they're starting. And I would mention also lamotrigine, not as an acute treatment, but you're putting it on for the longer term is something to keep in mind. So again, you're thinking, I feel, in bipolar, both acutely and that you're going to need to consider long-term treatment as well, unless you may want to add to that.
Yeah, so when I'm treating someone acutely, I always have in the back of my mind, what am I going to be doing next? And what am I going to be doing that's going to be helpful in the long haul? And that may be something different than what I'm doing right now. Right. You have to be flexible, and the past history of what they were adherent to and what they seem to do best on will drive a lot of your decision making. And barring that, if you're starting from scratch, I go for what's FDA approved, primarily because of the data that's out there that's usually, quite robust.
Yeah.
Which brings us to this other question: how to use Nntnh and Nntnh numbers to inform your treatment decisions in patients with bipolar disorder. Well, simply put, it helps me sort of gauge some of the differences and similarities amongst the choices. It helps point out some key differences. So in our exercise tonight, we went over the drugs for bipolar depression. We found that the number needed to treat for response or remission were in the same ballpark. So those numbers don't really influence me all that much. Yes, OFC had a more robust sounding number, but the 95% confidence intervals were quite broad amongst all of the choices, which means, you're going to need a head-to-head trial to really answer that question. So in the real world, you consider all four if all you're thinking of is efficacy. But we also think about tolerability and safety and the patient's willingness to take the medicine. And I know from the data that if I choose OFC every time, I'm going to be dealing with weight gain more often than I would want to. And if I chose quetiapine all the time, I would deal with sedation or somnolence more often than I want to. So I'd rather not deal with that. And I'm gravitating towards the two newer choices, lorazepam and cariprazine, which seem to tell me through the Nntnh effect size estimates that I won't encounter those adverse effects associated with those drugs all that often. Sometimes I will. And it depends on the patient too, right? So if a patient comes to you, they've been on quetiapine before, it worked terrific for them, they did tolerate it, they felt a little tired, but that was okay for them. Well, guess what? I'm going to use quetiapine for them because that's what worked for them before. So again, we have to use our heads here. And Nntnh and Nntnh are particularly helpful when characterizing new treatments for which we have very little clinical experience with and the patient has not been exposed to. It helps us gauge where this might fit in our armamentarium. So use it as kind of a guide, but you have to weave into the story your patient's values and preferences, their past history, and your clinical experience. Well, we have time for one more question here. All of the atypicals are only indicated for certain phases of bipolar disorder. Do you know if any had data showing they were effective for all phases, even if they did not receive official FDA approval? Well, that's a loaded sentence there, because number one, not all atypicals are approved for bipolar disorder. There's some exceptions, even though one of them works quite well for refractory patients, and we know that begins with the letter C, and it ends with ene, and it's clozapine Never approved for bipolar disorder, but boy, we have patients with bipolar disorder on it. Of course we do. Now, what about those drugs that are effective for all phases and have data to show for it? Quetiapine is one of them. So I have to hand hats off to quetiapine, approved for bipolar depression, bipolar mania, and for maintenance. Not all of them can say that, but all of them have some kind of data, more or less, suggesting that they may be helpful for the other phases. Now, for some, the data is very scanty and may be just isolated case reports and so on, but there's a rationale that perhaps you can get away with all of them for all the phases. But again, my preference, go for where the data is. Trish, your opinion?
Yep, I think that's well said. And also right now, quetiapine has the luxury of being the only atypical approved for bipolar 2 depression. That may change with lumateperone, but we'll see how that goes. In terms of that question, cariprazine is approved for both mania and depression. I don't think they have maintenance, though.
No, they're working on it.
Yeah. So I think you have to go with the data. I absolutely support what Les said. I mean, it's kind of the place to start and the place to finish. And if you can't get what you need with the patient in terms of stabilizing based on the data, then you have to go to the next level information, which is more clinical expert consensus and so on. But the patient's response is the most important.
Well, with that, nicely said and nicely concludes our discussion. That's all the time we have for tonight. To our audience, thank you very much for joining us this evening. For those of you viewing the live webcast, you will be redirected automatically to the evaluation form. For those viewing the live stream from a social media platform, you can claim your CME credits at integrityce.com/bp3_posttest.eval. And that's written there right on that slide. This link